Okay, good afternoon, everyone. Just for the final checking, camera and microphone. Okay, thank you, Mr. James. Final check. Start with Mr. James.
Hi.
Okay, right. Mr. Z. And test your mic, Mr. Z. Mr. Z. Z01. Mr. Sasi.
Hi, good afternoon.
Okay, right. Miss Crystal.
Everyone clear?
All right. Okay, Madam Pichi, Luna.
Yeah, can you hear any background from my end?
So far, so good.
No. None?
None.
All right, thank you.
Not very bad.
Okay, we will start about a few minutes to allow the others to join us.
So are you going to play some more videos? Then at the end, I think I will have to start. That's going to be my cue.
Yeah, unfortunately, we have a little bit technical error on the video. So we just start with your session.
Exactly at 2. Okay.
I think a few minutes, I will give a cue for you to start.
Okay.
Let me play, might be 2 songs first.
Okay.
Okay.
Thank you.
Mic test, mic test. Mic test, mic test, mic test. Boleh dengar ke? I don't think.
Okay, all right. So James, Madam Pichi, we will start in 2 minutes.
Do you want us all to turn on the camera?
Yes, all the speakers and all the delegates from other countries.
Hi, James. Hi. Hi, James. Can you hear me? Can.
Boleh dengar
Boleh. Ni Encik
Okey.
Sawah kat mana ni?
Dalam kereta lagi. Jalan jam.
Asyik.
Tadi tengok menu untuk next program.
Okay, Madam Pichiluna, I think it's all yours.
Hi, everyone from Asia, and to all our audiences from all parts of the world, and most especially to everyone from Malaysia. This is CPD Asia, the online continuing professional development platform for Asian Radiologic Technology Societies. And hosting the 32nd CPD Asia is the Malaysian Society of Radiographers, MSR. And I'm Pichi Luna, the CPD Secretary General and your CPD Asia program host. We are live streaming on YouTube. You can search MSR, PARI, or VART channels so you can join us live or watch a replay. This CPD Asia is highly supported and raised by member societies, presidents, all the officers, and their representatives. Let us greet and welcome Ms. Cora Nang, the chairman of Macau Radiologic Technologists Association, MRTA.
Sorry. Hello, everybody. Nice to meet you on the 32nd CPD Asia. Hello.
Hi. We also have the president of Perhimpunan Radiographers Indonesia, Indonesian Society of Radiographers, or PARI, Dr. Giek Sudianto.
Hello, everybody. Good afternoon. Pak Sawal. Salam, Pak Sawal.
We also have the president of Hong Kong Radiographers Association, Mr. Nang Tat Ming.
Hello, everyone. See you again in the 32nd CPD Asia program. Welcome.
Yes, hello. And we also have president of Taiwan Association of Medical Radiation Technologists, Sir Chun Yu Wan Tu. We have president of Singapore Society of Radiographers, President Denise Chung.
Good afternoon, everyone, and thank you, MSR, for organizing this session.
And we have also president of Indian Society of Radiographers and Technologists, President Selva Kumar. We also received greetings from President Vitarana Gamage Vimalasena of Society of Radiological Technologists, Sri Lanka, President of Japan Association of Radiologic Technologists, President Mr. Katsuhiko Ueda. We also received the greetings from the President of Macau Radiologic Technologists Association, MRTA, President Fernando Koch, the Vietnam Association of Radiologic Technologists, President Thai Van Loc. We also received greetings and welcome from President of the Philippine Association of Radiologic Technologists, President Rolando Benares, from President Sophie Lee of Association of Cambodian Radiological Technologists. And also we have received greetings from Mohammed Abdelghani, the president of Palestinian Association of Medical Radiation Technologists, PAMRT. And later we will be joined by our invited panelists who are also here today. So may I request everyone to open their cameras for a short photo session. All right, thank you, everyone. Before we start the program, so I'd like to please ask everyone to welcome the president of the Malaysian Society of Radiographers, President Sawal Marsaid, to give his welcome address.
Okay. Thank you, Ms. Pichiluna. Hi, everyone. All the president of the societies, all the participants, and welcome to our 32nd CPD Asia. And then now is today we are hosting the CPD Asia, and then for the 2023, we are the last societies organizing it. And thank you all the support from the societies, the speakers, and all the participants. I'm very sorry because now I'm still driving because just visiting the venue for our next program, for next year's program. So because now it's a school holiday in Malaysia, first day of school holiday in Malaysia, so the traffic is quite heavy traffic today. I didn't expect that, so I'm still in my car, but I'm with the 32nd CPD Asia. And again, thank you very much for all the support from all the societies, all the presidents, and the participant as well. Welcome to the 32nd CPD Asia. And thank you for the participation. And hope next year we will continue with this CPD Asia and more to come from the Secretariat of this CPD Asia. Thank you very much. Welcome everyone and enjoy the session. Thank you very much. Thanks.
Wow. So thank you so much for that warm welcome. Again, our president of the Malaysian Society of Radiographers, President Sawal Marsaid. Keep safe. So beginning the session now, let me introduce to you our session moderator from MSR. He is Mr. Muhammad Zirwan bin Ahmad Zainuddin. Our moderator started his career at Mount Miriam Cancer Hospital in Penang as a radiation therapist. Then he continued working at the National Center Institute Putrajaya as senior radiation therapist. Now he is the chief radiation therapist at Sabah Women and Children Hospital. For those who have attended the 2023 AACRT hosted by the Malaysian Society of Radiographers in Sarawak last August, you must be familiar with this charming and cheerful MC. Welcome, Mr. Zach Zirwan.
Hi, thank you, Miss Pichiluna, for the very kind introduction. So I take over the session. So Assalamualaikum and good afternoon, ladies and gentlemen. Esteemed colleagues and honored guests, a warm welcome to the 32nd Online Continuing Professional Development CPD on behalf of Malaysian Society Radiographers. As the host for this 32nd CPD Asia, we would like to thank to all of you for your continued support by joining us today. So before we begin, let me read a pantun as our Malaysia culture. Usually in Malay, but as we have our friend from international, so I try transform it to English. Okay. We are here today for 32nd Speedy Asia, introducing Dr. James, Mr. Sasidaran, Ms. Leong as our speaker, Society President, Mr. Sawal and Ms. Pichiluna, and I am Zach Zirwan as your moderator. Okay, so we continue with our presentation. Let me introduce our first panelist, technologist Dr. James Chong. He is the Director of Allied Health, Thomson Hospital, Kota Damansara. He is graduated from Teesside University of United Kingdom in Bachelor Medical Imaging, did his Master of Business Administration at National Institute of Business Management, India, and completed the Doctor of Business Administration at European Institute of Applied Science and Management, Czech Republic. He has been working at Macau Yinko Hospital as Radiology Manager and Chief of Clinical Ancillary Services. That was in 2020. So presenting to you with his topic, Unlocking the Secrets Body of Composition, how your weight, muscle, and fat impact health and chronic diseases. Dipersilakan, please.
Hi, James here. In today's presentation, I'll discuss obesity as a widespread clinical issue globally. I'll delve into various types of fat, explore the methods and common term used in body composition assessment, and highlight its clinical application. Additionally, I focus on specific patient group where assessing body composition plays a significant role. So today's aims to achieve several objectives. We explore how excess weight and low muscle mass plays a role in numerous chronic diseases. Additionally, we distinguish between the four types of fat, particularly highlighting the impact of visceral fat on health, I'll delve into various methods used to assess body composition and outline several clinical applications for these assessment tools. Lastly, we'll identify patient population that could significantly benefit from body composition study. Well, as many of you are aware, obesity has emerged as a global epidemic affecting not just adults, but also children. According to CDC, obesity is characterized by an excessive amount of fat in comparison to lean body muscle. The CDC defines this based on BMI, calculated by dividing a person's weight in kilograms by square of their height in meters. So obesity isn't limited to the United States. It's globally affecting around 400 million adults, as reported by WHO. Within the United States, staggering 78 million American adults are among the significant numbers. What's more alarming is about 30 million individuals falls under the category of morbid obesity, with BMI exceeding 45. Sadly, this condition incurs substantial costs for employees, totaling 73.1 billion annually due to lost workdays resulting from sick time, and also increase the needs of medical attention. So the National Institute of Health and WHO advocate for using BMI to identify overweight and obese individuals. This classification is based on data showing that the risk premature mortality typically starts increasing at a BMI of 25 to 29.9, further escalating at 30. However, factors like waist circumference, consistent weight gain since young adulthood, fitness level, and ethnic or racial background also influence the correlation between BMI and overall disease risk. Obesity is defined as BMI over 30, while individuals with a BMI between 25 to 29.9 are characterized as overweight. Well, you need to understand, and understanding the significance lies in the fact that obesity contributes directly to the development of numerous diseases, impacting internal body structures and organs. Conditions like cancer, including colon, breast, and prostate cancer, are influenced by obesity. Additionally, it plays a role in various chronic diseases such as gallbladder disease, pulmonary issues, cardiovascular problems, diabetes, and metabolic syndrome. What's concerning is that many of these diseases were traditionally associated with older adults, but due to poor diet and lack of exercise, younger individuals and even children are increasingly affected by these health issues. Well, the most significant consequences of obesity is the rise of mortality rates. Annually, there are over 100,000 preventable deaths attributed to various chronic and acute diseases linked to obesity, as mentioned earlier. Ultimately, obesity reduced the average lifespan by 3 to 10 years, making the second leading cause of premature death, trailing only behind smoking. So now we are going to move on now to different types of fat in our bodies, how they impact our health. Essential fat is crucial fat stored in vital organs like heart, liver, and kidneys, necessary for normal body function. It's not measurable by DEXA in areas like bone marrow or certain organs. Women carry extra fat in preparation for childbirth, and its absence can cause hormonal and reproductive problems. Non-essential fat is stored in adipose tissue and serves as a nutrition reserve, divided into two types, visceral and subcutaneous. Distinguish between these two categories is crucial in assessing body composition, and I'll explain further. Understanding body habitus or shape is crucial as it dictates the predominant fat distribution in individuals. The apple shape refers to fat accumulation around the upper trunk, while the pear shape indicates more fat mass around the lower thigh area. This significantly lies in the risk, cardiovascular issue, diabetes, and metabolic syndrome. This is due to major organs being located in this area, making a primary site for fat deposit. including both subcutaneous and visceral fat. Conversely, fat distribution in gynoid area, which is the lower body, reduce the risk of this disease as the fat doesn't stay close to the organs. So let's look into specifics of non-essential fat, particularly the subcutaneous fat and visceral fat. Subcutaneous fat is the fat layer just beneath the skin, just situated atop of the abdominal muscle, around 40 to 60% of the total body fat. Its main function is to store energy. On the other hand, visceral fat is found within or around abdominal organs, beneath the muscles, serve as cushion and safeguard internal organs. It's around 5 to 8% of total body fat in women and 20% in men. Research indicates that visceral fat is a risk factor for overall mortality in men. So, the visceral fat is risky for health, especially for heart conditions like hypertension. Smoking and drinking often contribute to its buildup. Unlike other fats, it's highly active, releasing excessive substance into important organs and causing inflammation in body. This type of fat also affects hormone levels in men and women. So in men, higher testosterone means less fat, but with age or aging, as testosterone drops, visceral fat increase. In women, more of this fat leads to higher testosterone and lower estrogen, affecting fertility. Furthermore, compared to other fats, visceral fat has more receptors that convert inactive cortisol into cortisol, promoting more fats built up. Long-term steroid use worsens this risk and can cause other health issues. Visceral fat found around organ can change subcutaneous fat into itself. It's released glycerol that turns into glucose in the liver, causing more insulin resistance. It also releases inflammation, causing chemical possibly leading to liver problems like NASH. Now we look into different types of body composition measurement. Now we understand the scope of obesity problem and the various types of fat. Let's look at the way of this measured the composition within our bodies. Hydrostatic weighting, an earlier method like DEXA, worked by using water and Archimedes' principle. It includes submerging the person under water, where the water force balance their weight, called buoyancy. Accuracy is affected by factors like breathing, exhaling fully underwater, helps minimize error. It measures three things: body weight in and out water, and water density. Using this and calculate body fat percentage. So air displacements like hydrodensitometry, but with air instead of water, uses Boyle's law to measure body composition. There are two types. One is for the adult and one is for the children, but it has drawback. Patients needs to be clean shaven and wear specific clothes, which can affect the result as well. Inconsistency in movement and breathing also impair accuracy. And it's really costly, large, and intimidating, with 1 to 3% of error rate and only offers total body calculation. Bioelectrical impedance measure the body electrical resistance, where muscle have less resistance than fat. This method accuracy is highly influenced by hydration level. Low water levels can show higher body fat reading, while warmer skin conduct electricity better, potentially displaying lower body fat. In contrast to DEXA, fat measurement changes by less than 1% with different levels of limb mass hydration, falling within precision error range. So another two types of measurement: skinfold and circumference measurement. Skinfolds use caliber, as you can see. It measures the fat thickness at different spots. It contributes about 4% difference among tester, and the other way is measuring the curve around waist circumference. This method may overestimate body fat in muscular people. Another method is weight to hip ratio using a TAP measurement. It also can give varying accuracy. So we do have MRI. That MRI can assess body composition are challenging, and the signal, because the signal inhomogeneity potential necessitating specialized imaging coil, and it will be not available, achieving consensus on quantitative imaging protocol, so on and so forth, and also is very costly, although it's very useful to a segmentation of automated organ to look at the fat distribution. So this is a comparison where the DEXA compared with other measuring techniques. You can see DEXA is the most reliable and cheap and lower dose kind of measuring technique. So what is DEXA? DEXA scanner captures dual energy attenuation data for every pixel in the image. To ensure accuracy, it uses calibration standard usually made of plastic, which are scanned using the dual energy X-ray beam. Plastic and soft tissue both absorb X-ray similarly, allowing plastic to serve as standard for fat and lean tissue in a whole body phantom. By comparing the X-ray attenuation from each image point to the calibration curves obtained from measurement of these standards, the scanner calculates the fat and lean mass for each point in the image. So as mentioned earlier, one limitation of DEXA is incapability to direct measure the soft tissue composition within pixels containing bone. While it can measure total tissue mass, it relies on estimating the lean and fat components from surrounding tissue point. So what does DEXA measure? DEXA looks at 3 parts: fat, lean mass, and soft tissue around bones. It gives a detailed look at the whole body and specific area. Lean mass includes everything except fat, like bones and muscle. Calculating just lean mass can be tricky, so fat and fat-free mass together are usually used. DEXA assumes the body is about 78% water, helping keep the result consistent. It also measures bone and total mass, which is the sum of these 3 parts. So DEXA provides a complete picture of these quantities all over the body. So the software used for assessing visceral fat highlights the important area in an image. It shows where the subcutaneous fat and visceral fat are located. By figuring out the difference between these areas, and soft tissue calculates the amount of visceral fat, it automatically marks area in the abdomen and measures visceral fat accurately. So DEXA gives a 2D view, but visceral fat exists around bones, causing overlap. CT scan, 3D alternative, have more radiation and costs, but offer a detailed view. A study compared DEXA and CT scan at L4, finding DEXA performs similarly for measuring visceral fat. DEXA estimates visceral fat by using abdominal subcutaneous fat, inferring visceral fat levels from total abdominal fat measurement. So knowing how much visceral fat a person has is crucial in healthcare. While visceral fat data is measured in mass gram and volume centimeters cubed, the area in square centimeter of the abdomen is key in setting risk level for heart disease, diabetes, and metabolic syndrome. These thresholds vary based on gender and different diseases. Visceral fat strongly relates to health risk and mortality in men. For women, risks are often observed between 70 to 110 centimeters square, while men faces high risk starting from 125 centimeters square. This information helps you predict future health risk. It's valuable tools for doctors and patients to work together to coordinate intervention and lifestyle changes to reduce the risk. So, can you reduce visceral fat? Absolutely yes. With a good weight reduction plan, even a small 5 to 10% loss in body weight can greatly improve markers for chronic diseases like diabetes and metabolic syndrome. Visceral fat is highly responsive to weight loss efforts because it's actively involved in your body metabolism. By reducing visceral fat, you are reducing factors that cause weight gain and lowering inflammation, which is at the core of metabolic disease. This often results in overall feeling of improved health as your body gets back in balance. Some people who think they are healthy weight might actually be medically considered obese due to undiscovered insulin resistant and metabolic issue. Initially, insulin resistance might prevent weight gain, but if it sticks around, it can lead to more health problems. Surprisingly, those with a history of low birth weight or who were lighter as kids might develop belly fat later in life. Certain ethnic groups like Japanese might have a lot of belly fat even with healthy lifestyle, often because of genetics. So this DEXA composition scan shows a person who appear to have an average total fat percentage for their age. However, when focusing on the visceral fat number, a different scenario unfolds. As we discussed earlier, visceral adipose tissue exceeding 160 grams per square centimeters signifies a higher risk for severe metabolic disease. So this is the part that DEXA cannot measure, as we have discussed earlier. So the National Health and Nutrition Examination Survey is a huge national study that collected information about for body composition for more than 20,000 people over 5 years. It includes data from individuals aged 8 to 85, representing 3 ethnic groups: white, black, and Hispanic. This database isn't evenly spread out. The average and middle fat and lean levels are different. That means the upper and lower levels aren't the same. To handle this, the survey used percentile rather than just comparing to the average. So there's a discussion whether BMI or FMI is a better way to measure body composition. BMI is the usual method to check fat in obesity, but it might not be always the best. BMI mostly look at the extra weight, not just the extra fat. Some people suggesting using FMI. Instead, they look at the lots of information and separate fat data from lean data to get more accurate numbers. So this way, they could make it different for men and women. They make groups like those from BMI make them better for each gender, aiming to gain more precise picture of the body makeup. So they have published a reference level based on the athletes across various sports, including archery, shooting, basketball. It aims to establish published reference values specifically for male and female athletes in these sports. So when we compare the categories of FMI to those BMI from the WHO, we see that FMI focusing on fats and not muscle is made separately for men and women. These groups are similar to BMI group, but a bit different. For example, the normal BMI range is 18.5 to 25. In comparison, an FMI or 3 to 6 for men, 5 to 9 for women show similar rates as BMI for younger healthy people. So DEXA body composition assessment offers a unique advantage. Unlike most other methods that gives only an overall view, DEXA allows for detailed examination for a specific area in addition to overall analysis. This gives a more comprehensive understanding of body composition. So what is the clinical application? So folks involved in weight management, from those undergoing an exercise program to individuals considering bariatric surgery, can really benefit from DEXA composition. Post-bariatric surgery, where nutrition absorption changes affect fat and lean mass, monitoring this aspect becomes crucial. With a growth factors or focus on preventive wellness, many centers now offer comprehensive programs including body composition. So DEXA body composition assessment have proven immensely beneficial for several groups. People who had bariatric surgery, as I mentioned before, to ensure their weight loss primary targets fats, not muscle loss. Fitness enthusiasts, which they find it valuable to tracking muscle gain and reduce overall body fat, and also pediatric patients that dealing with malnutrition. So a comprehensive human performance enhancing program incorporates a tailored approach to body composition management. This includes implementing and optimizing nutrition program that aligns with specific performance goals. The combined focus on training and nutrition aims to improve athlete performance, promote muscle development, optimize energy level, and enhance overall physical capability. So it also helps to assess injury prevention and recovery. So the body composition data is highly valuable for athlete program coaches and trainers. It provides detailed insight into an athlete body, preventing injuries and guide recovery. This is how and why they wanted to use DEXA for preventing injury for athletes. This, by closely monitoring changes in muscle mass during rehab, coaches can refine strategies for optimal recovery and performance after injuries or even surgeries. The detailed insight from body composition analysis help ensure balanced muscle development among athletes across different sports. This information focusing on muscle mass and bone density throughout the bodies allow coaches to fine-tune training routines. This adjustment aims to create more uniform muscle development, lowering the risk of injuries. Coaches can use this data to customize training program, correcting imbalance and improving overall physical condition for better performance and injury prevention. So for personalized nutrition plans are crucial components to training and weight loss efforts for both patients and athletes. This tailored strategy matches individual goals, whether it's shredding weight, maintaining muscle, or building it. So these are I'll show you some example. This is done by SP. So let's have a look at the video.
At ASPI, we engineer elite athletes using better science. We look at athletes across a wide spectrum of individuals, from elite youth all the way to elite professional athletes. What draws them to the Institute is that cutting edge technology. They want the guesswork taken out of their training and their programming, so they know exactly what to do to get to the next level. Push. We want to take the guesswork out of body composition. Most body composition measures just tell you holistically, oh, this is your body composition in general. The biggest difference between the hologic DEXA and other forms of body composition is the specificity that the hologic DEXA gives you. We always take DEXA scans as a baseline at the Institute. It's the first thing you do is look at their body composition before we do any other type of test. It's not good enough to just know someone's overall body fat. It's not good enough to just know how much total lean mass that they have. We want to know where that lean mass is, where that body fat is.
One of the things that we can do is we can customize nutrition plans based on someone's starting lean body mass and body fat percentage and what their goal is.
We noticed that I needed to put on X amount of lean tissue going into the show, and I only had 11 weeks to be able to do so. So that directly dictated how much my calorie intake needed to be throughout the day.
After the nutritionist really works with the athlete using the hologic DEXA data, one of the things we do is we sit down with our strength and conditioning coordinators and really go over muscular imbalances to create the ultimate program specifically for that athlete.
Both athletes and coaches absolutely love the fact that the hologic DEXA is visual. It's visually appealing and it's easy to understand. Because the bottom line is that the athlete has to understand, and a picture is better than 1,000 words.
I think that the DEXA definitely helps keep people on track and keep people motivated, because when you're constantly seeing, I have 18% body fat, now I have 17.5% body fat, 16% body fat, and you know how precise the DEXA scans will actually be.
No way! Our ultimate goal using the hologic DEXA is to engineer the ultimate athlete.
Okay, so let's move on
At ASPI,
for another video.
For nutrition analysis in our NFL Combine program, we use two specific kinds of equipment. The main one is our hologic DEXA, which we use it basically evaluating the body composition data for the athlete. Look at the lean mass, fat mass, and all the body composition to the T to understand exactly how we're going to manipulate the nutrition programs according to that. The second piece of equipment that we use at the Applied Science and Performance Institute is the metabolic card test, which we use it to understand the caloric needs of our athletes and our players to really understand what nutrition programming we really need to put them on. When we look at the data from the hologic DEXA, we want to understand the specific points or areas that we really use for refining the programs of the athlete. One of them is specifically lean mass. The second one is body fat percentage. The other part that we also use is fat mass as well. From last year, we have some of the most incredible results where athletes gain up all the way up to 14 to 15 pounds of muscle and losing up to 4 or 5 pounds of fat at the same time. So the net gains in weight, they're minimal, but then when you look at the body composition changes, that's really what we're expecting to see. One goes up, the other goes down, so the net weight sometimes doesn't change as much. It's really the data that we get from hologic DEXA to be able to really get the specific data points and the numbers to understand exactly what they accomplished through their time here.
Okay, so let's move on to the next one. So as you can see, this is the results that from the DEXA scan. So it will tells you all your upper limbs, your trunks, and lower limbs. And if you have done a comparison, if you've done a study before, you can see your comparison, is it reducing or increasing? So take note about this results that are done in 2 different dates. I've done a comparison with the BIA. So you can see actually there's significant difference. So the accuracy for BIA is lesser compared to DEXA. So in short, the obesity problem is constantly changing, caused by various factors, yet there are several hopes solutions on the horizon. The bigger deal about this issue is to put it today's kids at having risks and a shorter lifespan compared to their parents, which is a concern for now. So this is the the take-home message that obesity is really a concern and epidemic to threats all the generation for now. So I want to take a little bit of time to talk about another thing that also affects our health, well, mainly due to for older generation. We call this condition sarcopenia. Sarcopenia refers to the age-related decline in muscle mass, indicating the reduction in muscle quantity over time. So the percentage of loss in lean muscle or lean mass is associated with the complication in increased mortality rates. So this is a definition or the index that we use to calculate sarcopenia. So the current status of knowledge, well, complex of several factors that includes regulations of protein synthesis and degradation, genetic influence, the natural decline in secretion, and the factors of hormones like growth hormone, so on and so forth. So understanding how body composition assessment can help screen for potential issues in overweight and obese individuals with muscle loss is really important. In many countries, more people are becoming overweight or obese, and they are also getting older and less active, which can lead to health problems like chronic disease and cancer. This situation increases the chance of people losing important muscle mass. Normal methods like checking weight or using BMI aren't good enough to spot this muscle loss or undernutrition, which can get worse and harm health. However, using special body composition like DEXA, it checks early on, can find undernutrition in overweight or obese people with muscle loss. When found early, it allows for quick help with nutrition, which might improve or how healthy they are in the end. So this is the challenge. These are the challenges that in screening for sarcopenias. So it involves specific issues related to the patient's condition and equipment used for measurements. So, but still, what's to do to counter the muscle loss is weight training and a proper nutrition program. It's just a small take-home message that I wanted to let you all know that many people actually thinks that for older people, the losing bone density is crucial, but actually another problem is with losing muscle mass will cause more important issue, and the the entire musculoskeletal is attached together, so losing muscle will decrease the bone density in leading to more problem. For example, if a person is fragile, they fell down, it can cause muscle injury or even fractures. So that will reduce the quality of life, or for older people, it can cause fatal issue. So that's the end of my slides. Thank you.
Terima kasih. Thank you to Dr. James Chong for the interesting topic. So I would to remind, if you have any question, you can type in the chat box below and we will discuss it at the last session. Okay, so now moving along to our session, Mr. Sasidaran, anak lelaki Ramachandran, will be the second panelist. He is the senior diagnostic radiographer at University Malaya Medical Center. He is graduated in Advanced Diploma Cardiovascular in Healthcare Imaging. His subspecialty in cardiac angiography since year 2001, and currently he is the supervisor in Interventional Catheterization Lab ICL at UMMC, University Malaya Medical Center. With his topic, radiographers' role and their PlayStation in interventional cardiovascular laboratory ICL. Mr. Sasi, the session is yours.
Thank you very much, Mr. Moderator. Are you able to see my slides? Yes, can see.
Yes, can see.
Okay. Okay, a very good afternoon to everybody. My name is Sasidaran, radiographer from University Malaya Medical Center. Before I go on into my first slide, I would like to actually thank Mr. Sawal, President of MSR, and his AGT for inviting me for this 32nd CPD Asia. Well done, and thank you again. My topic for today is radiographers' role and their PlayStation in ICL UMMC. Okay, as you can see, it consists of a multidisciplinary team, compromises of cardiologists, nursing team, radiographers, and MA, MLT, or even some places we call it as CVT, cardiovascular tech. As you can see in the picture, you tend to get confused, especially when you're a newcomer coming into the cath lab. You wouldn't know who's who, right? When you're having 4 teams compromising of cardiologists, nursing team, radiographers, and CVTs. So how do you know who's who? This is always what do you call it? A funny thing that always occur when I tend to see a new staff coming into the lab. I tend to get confused, not knowing who's who, right? So I will always approach them and tell them that if you're looking for a radiographer, and this will be my answer, look for the good-looking ones in the cath lab. So this is actually my team, my small team. Without them, I don't think I'll be here right currently. So I would like to say thank you to them as well. Okay, let's go to our topic, which is the radiographer's role in the cath lab. This is the general review in ICL. We have 3 labs, which is all 3 labs are under the Philips vendor, under Philips Allura Expert and Philips Clarity. And we do have a hybrid lab as well. Okay, role split by radiographers in ICR based on the Journal of Public Health, Nursing and Medical Rescue in 2014. It stated that the role of radiographers in the lab is actually responsible for imaging the heart in a number of projections to demonstrate each of the cardiac arteries and areas of occlusion and nerving. Just to get a 3D mapping of the coronary arteries. That is the reason why we take a number of projections in each coronary arteries. Okay, but we tend to forget, the radiographers tend to forget that that's actually not the actual role that they play too. They have a more important role in the cath lab, where their core job is actually to minimize the risk of radiation for the patient and for the staff as well. And the second thing that I will always tend to notice, that we always tend to neglect the maintenance and operation of the angiography equipment, which I've always tell my colleagues that it's very important that we do a daily Q&A, which is the quality assurance of the machine. But there's no point of us owning the machine and then go have our breakfast, and then when you put it on the patient and then we start doing the angiogram, the machine breaks down and some interface of the machine doesn't work. So that is also a main thing that we always do in our SL, to maintain an operation of the angiography equipment. And of course, since you are doing the cath lab, you should know your cardiopulmonary resuscitation as well. And always apply the radiation protection principle, which is the ALARA. That is very important. That I always remind my radiographers and also the new radiographers, junior radiographers, which is coming for training. Okay, based on this picture here, this is actually the common view or the common procedure that is being done in ICL. So this is actually how do you minimize the radiation that is involved during the procedure. You can see that, you can see as my cursor is moving, this is below the tape, under the table is actually the X-ray tube, and near the patient is always the detector, right? So make sure that the detector is always close to the patient. That is actually to reduce the scatter of radiation. And of course, you do collimate during the procedure. And of course, again, it depends on the operator, which is the cardiologist. If he minds for you or the radiographer to collimate, you collimate accordingly. You do not collimate too small of a FOV, where it doesn't actually give you a diagnostic view for the operator. So collimate accordingly based on the procedure that's being done. And then position shield in between the patient and the operator. This is actually the glass shield. Okay, it always position between the detector and the operator. And of course, in some cases, in some cath lab, they do have the radiation safety cap. Even I myself have it. As you can see, the radiation cap, it has a thin layer of a lead, which is protect the operator as well as the staff in the ICL. And of course, radiation safety glass is always a compulsory kind of a thing. And do you put in the lead skirt and vest with thyroid collar? Okay, this is another thing that we are the role of the radiographer needs to come in and let the operator know, because most of the time, or not most of the time, I mean, when you tend to see or observe the newcomers or new fellows coming into the cath lab, they tend to scrub up without wearing the lead gowns and all. So it is your duty or the radiographer's duty to actually remind them to wear the lead gown first and then wear the stop. And of course, disposable shielding, this is not compulsory as well, but in certain centers, they do have it. Okay, and the movable lead skirt, it comes together with the machine itself. Okay. This is another important diagram which actually minimize the radiation risk between the patient and operators. Okay, we go to the patient first. How do you reduce this? By increase the table height, vary beam angle, keep extremities out of the beam. Depending again with which examination I will. If it's for me, it's going to be the cardiac angiogram. It's going to be most of it is going to be the cardiac muscle or the coronary arteries. So you don't have to actually include the thyroid or the diaphragm during the fluoroscopy or the position of the CD. Okay. For the operators, again, like I said, protective garment, which is the lead gown, thyroid shield, and all. Increase distance from the source as long as you are within the distance of safe distance, you are quite safe to go. optimize shielding, of course, like the previous image which I showed you just now. Keep body parts out of the beam, especially the operator when you are inserting your catheters and all that stuff. You tend to put in your fingers or your hands into the field of the radiation. You tend not to do. You can actually, the role of the radiographers is actually to inform the operator not putting their hands while the thing is being x-rayed. And robotic cath lab, if there's anybody from the ASEAN region who has robotic cath lab, can actually let us know in the comment below if you have a robotic cath lab. But in UMMC, we don't have a robotic cath lab. So I would like to know if you have a robotic cath lab and how it does minimize the radiation and all. And to reduce the radiation between the patient and operators, these are the main thing that the radiographers need to do. Limit radiation usage, of course, when the operator is actually pressing the pedal and in a prolonged period of time, you can always remind them, doctor, the fluoro time is quite long. You can always ask them to stop and fluoro again during the procedure. Decreased cine usage also does help and minimize steep angles. As you know, the steeper the angle that you go is going to increase the more of the KV and MES during the procedure. And of course, keep the detector close to the patient, and that's to actually to reduce the scatter radiation. And of course, if you're able to decrease frame rate, you can always recommend the doctor to reduce the frame rate. For cardiac, for your information, cardiac angiogram, we tend to have a default setting under 15 frames per second. But I heard that there are centers around the world that they use 7.5 frames. So it depends on the operator as well. Okay, use software magnification as well. I tend to use software magnification most of the time rather than magnifying during the procedure. Why? Because every time that you magnify each step, you go higher and higher, radiation tends to go higher and higher too. Okay, real-time dose monitoring is standard, and you have to collimate. I tend to collimate most of the time, and I do encourage my radiographers to collimate as well, and that actually reduces the radiation during the procedure time, and also for the patient and for the ICL staff as well. Role play by the radiographer again under the same topic. This is actually the interface of the Philips machine that we have in ICL UMMC, where you can see in the first diagram here under the patient, it has box saying the patient's height and weight. By putting the patient's height and weight, you are actually telling the machine or indicating the machine that the patient is either medium size or in the larger size. If it is in a larger size, the machine will actually increase the kV accordingly based on the setting provided. And the machine's interface for this fluoroscopy is always on the default setting, is in number 2. And then number 1 is always the low fluoro, and the third one is always the high fluoro. We tend to use number 2 under the default setting. When I notice that if the patient is small and thin, I tend to go on low fluoro as well. That again is to minimize radiation for the patient and also the staff. And here again is the other the front page of the interface is you can choose the frame per second, how many frames per second. You can see here it's 15 frames per second. The next one is 7.5 frames per second. So you can actually play around with the frames per second, of course, with the cardiologist's consent. All right. The pre-procedure, I wouldn't go during procedure and post-procedure because that will be actually another topic which I don't think I have time to explain. But nevertheless, I will just go into the pre-procedure as well. What do we do during the post-procedure? Again, the first thing that we always do is the daily quality check, which is done daily, every day before the procedure is done. Of course, you are always X-ray disabled, and when you're doing the identifying of the patient when the patient is on the table, patient should be countable as possible. Patient creatinine level and the type of contrast are determined based on the patient's creatinine. Okay, injected contrast is needed if necessary. Okay, now we go to the second topic, which is the PlayStation time. The games application all must know during in the cath lab. The first is the QCA, the quantitative analysis. Second, stand boost. The third is rotational angio 3DCA, and the fourth is QFR. I did it in this order. There's a reason for that. Of course, we'll go to the QCA first. QCA. What is the functionality of QCA? It's a worldwide accepted standard. It is used to determine vessel size and length, and to help the operator to determine the size of the balloon and stent to be placed in the arteries which has stenotic segment. The results of the QCA that we can get is always minimum luminal diameter, reference diameter, percentage diameter stenosis, and the length of the stenotic segment. To look at how does the QCA works, is just as in this picture in front of you. You can see this is the catheter, and then this is the contrast, which is filling up the coronary arteries. And you can see the C shape is actually the RCA, which is the right coronary artery. So what do you do when the doctor asks the radiographer that he needs to do a QCA? He wants to know what's the percentage and the length of the stenotic area, and again the diameter of the proximal and distal end of the vessel. So the radiographers will actually take this run and choose the frame that it is intended to do the QCA, and to look at the proximal, the normal proximal and the distal vessel, and then to look at the tightest spot of the frame. So what you do is you actually click on the proximal part of the vessel, and you double click on the distal part of the vessel, and then the software will actually recalibrate and calculate, and this is what are the numbers that is given to you, and this is how the cardiologist will actually determine the size of the vessel and the length of the stent that is going to put into the vessel. Stent boost. Stent boost is a non-invasive stent visualization, and it's quite important currently in UMMC, where we tend to do a lot of stent boost images for every PCR work which is done in the lab. Okay, the technology of the stent boost enhances the stent while fading out the background noise and anatomical structure. This enhanced visualization shows the fine details of the stent struts when the stent strut is deployed within the coronary artery wall. So we do the stent boost is actually to actually look at the stent struts, whether it is actually wellly opposed on the structure of the vessel wall. So this is the movie time. Let's look at the first stent boost run here. Sorry. As you can see in this first stent boost image, right, on the video, you can see that there's two stent struts within the vessel. And the second movie, or the second stent boost video, will be this. As you can see, the stent. Why I'm showing you these two stents videos are because stent boost can be done not only in coronary arteries, but it can be done in vascular peripheral arteries as well, and also in carotid artery as well. Now we go to the rotational angle, or you call it expert swing. The functionality of the expert swing is actually replace the two single axis run with one dual axis run for the left and right coronary artery. Unlike the conventional coronary angle, it requires multiple stationary views. The C-arm rotates in curve around the patient by combining a few diagnostic shots in a single run. The advantage of doing a rotational angio is reducing contrast and also radiation exposure to the patient. Why do I say that is, when you do a conventional angiogram, you tend to take each run, each run you just have to inject the contrast, and you take a single run. So when you do a rotational angio, you just have to inject once, and you tend to get all the 3D mapping of the coronary arteries at one go. 3D coronary analysis is actually the same thing as what you call that as rotational angio, but it comes with the software of 3D coronary analysis. What it does is the functionality is to uncover overlapping branches when looking at the bifurcation. What are the advantages? Is most beneficial in viewing angle. Proper projection can be determined without using additional extra dose. Desired viewing angle is chosen. This is actually when the patient is having a CTO, which is a chronic total occlusion vessel, where there is a collateral from the right. The example of the right is giving a collateral to the LAD, which is the CTO. So you can actually do the rotational angio, and you can see the collaterals which is supplying to the LED in a angle that can be seen clearly in the 3D coronary analysis. So I'll show you how to do the coronary analysis. This is how you do a 3D CA. It's exactly the same like the QCA which I showed earlier. When you do the cine run and you choose the vessel based on the frame which is indicated, and then you click on the proximal, and then you double click on the distal, and you get the 3D CA vessel. As you can see here, every time that you move the vessel, it gives you the angle which is desired. And of course, it tells you the length of the segment which you, when you are studying, which is at this currently is 124 millimeter. As you move the ring, the green ring and the yellow ring, it tends to shorten the length of the segment which you are manipulating. And this is also another 3D CA which is done, and it's always used in cerebral angiogram. And this is the example of how to do it. NQFR, quantitative flow ratio. This is actually a new software which is currently important, where it is actually a physiological study which is being done in every cath lab, where the consensus between the cardiologists, where they tend to do a physiological study which is the QFR. It's a non-invasive coronary imaging to assess the functional significance of the coronary artery stenosis. It actually provides an estimation of the fractional flow reserve. What it's trying to say is when you do an angiogram and if there's a stenotic segment which is not really, what do you call it, to do a PCR, then they will actually do a QFR to identify whether there is any flow limitation to the coronary arteries. It's actually a computation process. It's run under the AI technology, and the clinical utility allows the clinician to determine whether a stenosis is hemodynamically significant and likely to benefit from the intervention without the need of additional invasive procedure like putting a pressure wire, which can actually dissect or perforate the vessel element. This is actually the QFR image, the interface, and the results outlook. As you can see, the interface, it has a series of selection, frames selection, offset correction is something similar to QCA as well. And then as you can see, the final result is actually a 3D CA image, right? So what I'm trying to say is QFR is actually a combination of QCA, 3D CA, and FFR, which is the pressure wire. Combine all three together, and comes up with this QFR application. Advantage of the QFR, it eliminates the need of additional invasive procedure, like I said before. Cost effective, it doesn't require any pressure wire and additional images run and all. Reducing patient discomfort and procedure complication. The disadvantage of QFR is you need to get a quality angiographic images and vessel selection as well. And it may be less accurate cases when it comes under complex anatomies or heavily calcified vessels. QFR does not provide time physiological information, unlike pressure wire, where you go into the coronary vessel during the real time. And the other PlayStation in ICL UMMC that we have is IVERS, OCT, FFR, and IFR. The reason I didn't mention this in the earlier slide is because these modalities are done by the CVTs in my lab. But nevertheless, I will just go through for the CME purpose. What is IVERS? IVERS is actually an intravascular ultrasound. It's a catheter equipped with an ultrasound transducer and strip. So what you do is that the wire which has the ultrasound tip goes into the coronary arteries. It actually measures and provide information of the vessel wall, assess plaque characteristic, and guide intervention has made it available for the imaging modality. What are the limitations? It does not provide information about the blood flow dynamics, which is in the pressure wire technique or PFR. Whereas for the OCT, which is optical coherence tomography, it provides a high resolution cross-sectional image of the arterial wall. It is assessed of the it gives you an assessment of the vessel lumen, plaque morphology, and stent deployment. The limitation for OCT is limited imaging depth compared to IVUS. And the advantage of the OCT is always visualizing the plaque morphology, optimized stent deployment, and it's always a valuable tool for guiding interventions. The third will be FFR, fractional flow reserve. Again, this is actually the pressure wire which I just mentioned just now. It helps guide treatment decision between significant and non-significant stenosis. The limitation for the FFR will be arterial injury, bleeding, or infection when the wire is going into the coronary artery, where you can actually perform dissection or perforation for the vessel. The advantage of the FFR will be it's a gold standard for assessing the functional significance of coronary artery stenosis. And in fact, for IFR, instantaneous wave-free ratio, is actually a simplified version of the FFR. It eliminates the need of hyperthermic induction, where in FFR, we need to give adenosine during the process of the FFR. For the limitation of IFR, it actually relies on a specific time point in the cardiac cycle where it is called the free waveform, where it detects during that time. And the advantage of IFR is to demonstrate that IFR has similar outcomes to FFR.
So if you want to change the world, start off.
So my take-home message will be, of course, the daily Q&A that you need to do, and then understanding the basic principles of ALARA, and of course, patient and staff safety in ICL, where the radiographers need to know and understand that they play an important role in ICL when it comes to radiation protection. I have a video which is quite a favorite of mine, where he's actually a commander of the Navy SEAL, Commander McRaven, stating about the simplicity of life and how it's important in our daily lives. Please have a look.
By making your bed. To change the world, start off by making your bed. If you make your bed every morning, you will have accomplished the first task of the day. It will give you a small sense of pride, and it will encourage you to do another task, and another, and another. And by the end of the day, that one task completed will have turned into many tasks completed. Making your bed will also reinforce the fact that the little things in life matter. If you can't do the little things right, you'll never be able to do the big things right. And if by chance you have a miserable day, you will come home to a bed that is made, that you made. And a made bed gives you encouragement that tomorrow will be better. So if you want to change.
So with that, thank you for your attention. These are my reference, and thank you so much. And see you again. Bye.
Thank you to Mr. Sasidaran for the knowledgeable topic. So don't forget to make your bed. Start tomorrow. Terima kasih. Again, a reminder, if you have any question, you can type in the chat column below and we will discuss it at the last session. And now we come to our final panelist, Ms. Leong Boon Ching. She is the radiation therapist at National Cancer Institute Putrajaya. She's graduated from Open University in Bachelor of Psychology and completed her master program at University Kebangsaan Malaysia last year. She has been awarded in third place in a poster presentation, IKN Research Day 2018, and first runner-up of a poster presentation at Postgraduate Colloquium 2020. Presenting to you with a topic, fatigue and those-related toxicities post-head and neck radiotherapy. Dipersilakan.
Thank you, Mr. Zach. Let me share my screen to you. Okay. A very good afternoon and Salam Malaysia Madani. A very warm welcome to each and every one of you from different countries present here today. So I'm going to share my sharing today, fatigue and those related toxicity post head and neck and radiotherapies. So according to the Global Cancer Statistic 2020, head and neck is the 7th most prevalent cancer globally, and the global cancer of head and neck has been increasing in many countries, mostly in men populations, with a predicted of 30% annual growth incidence by 2030. And type of head and neck cancer is referred to the group of malignancy that arise from the squamous cell lining the tissue of head and neck region, include the nasal cavity, paranasal sinuses, lips, oral, salivary gland, tongue, nasal, oral, and hypopharynx, larynx, trachea, as well as esophagus. So the common treatments for head and neck cancer is include with radiotherapy, chemo, and also surgery. So what is actually fatigue? According to the NCCN, fatigue is a distressing, persistent, a sense of tiredness, and also the exhaustions related to the cancer or the cancer treatment that is not due to the activities that is interfere patients' daily functionings, which typically recover by rest. So the prevalence of the fatigue at the initials of the diagnosis, up to 40% of the patients definitely associated with the number of arise in between 80 to 90% during the chemo and also radiotherapy. Especially it's high during chemo alone itself, and also CCRT, which means a concurrent chemo radiotherapy. According to the study, if patients they experience increase of fatigue during treatment, the chances of survival may be decreased, and high percentage of non-adherent treatments and hence affected the treatment's effectiveness. So let me touch on nowadays new era of artificial intelligence. Radiations induced toxicity can be predicted using radio and also dosimetric machine learning approaches. So recently, the advancement of the machine learning and the radiomic has provided a new method for toxicity predictions. It is a model using image-based radiomic features extractions from the regions of interest and also the radiomic features applied by the dosimetry segmentations to predict the occurrence of the toxicities. So this model, it is for predicting the toxicities, expand the applications of the machine learning in the field of radiotherapy, and promote an effective development of the toxicity predictions. And in this chart, it shows that the overall toxicity risk profiling in the head and neck radiotherapy. So a standard dose of the primary and lymph nodes involvement with the range of dose that will be given is 66 to 70 gray. For the prophylactic dose, which is not involved by lymphatic nodes in the neck regions, within the dose is within range of 45 to 60 gray. While for the post-operative treatments, radiotherapy will be given within 60 to 66 gray. So the overall toxicity profile show a clear dose response on the fatigue pattern with the RT toxicity symptoms that peaking at the end of the treatment and is slowly recovered within 8 weeks. It persisted up to 3 months post-RT. For some patients, their recovery condition might be delayed and it's resulting fatigue in a chronic phase. As patients will experience more severe fatigue symptoms as the and also the prolongations of the fatigue, it will be increased with the dose and also the fractionations of the treatments. So how does the RT dose affect to the organ at risk in relate with the fatigue. So let me start with the salivary domains. Salivary domains, the salivary toxicity is associated with the intricate dose, buccal mucosa, oral cavities, parotid gland, and also submandibular gland. And an early effect of the radiations to the salivary gland is include xerostomia, sticky saliva, and also loss of taste. Some include atrophy of the salivary tissue, which are usually concomitant with the fatty infiltrations, and it leading to the progressive reductions of the size of the gland, and also parenchyma loss is actually expected to be more prominent in the parotid gland, but it may vary depending on the primary site of the lesions and also the radiation field. Let me share a case study in here. It's indicated that early post-RT changes in the parotid and also submandibular gland, presenting in the MPC patients with 37 years old men. So this noted that the heterogeneous enhancement of the superficial part of the parotid gland and also parenchyma loss on the left parotid, as I showed here in the arrow C here. So another is the submandibular gland, indicate decrease in size over this area. It means the celladinitis is presenting, and also is also demonstrating an edema as shown in the arrow D. So here. Okay. So in the mucosa domain, and we have the dose predictor is oral cavity initially with the ulcerations followed by mucositis with the increasing of the fractions. So according to the WHO oral toxicity scale, grade 1 patient will start with erythema. Grade 2 is patchy ulcerations over here, as you can see here. And the grade 3 is complete ulcerations, and patients, they couldn't swallow food at all. And grade 4 is tissue necrosis, spontaneous bleeding, and extended that elimination is not possible at all. So the intensity of the early mucous membrane reaction is the major factor limiting the daily and also the weekly dose accumulations in the treatment of the head and neck. Example, a schedule of 70 gray delivered in the 2 gray per fractions over 7-week treatments, it leads to spotted complete mucositis in most patients. Okay, as the muscle undergo mild progressive fibrosis and also fiber, the atrophy after the radiation. So after the radiotherapy, when it reached the maximum tolerations of dose, oral desquamations occur around day 12, and it's recovered after the treatments 2 to 3 weeks time. Okay, so here's a case, late post-RT changes in the mucosa in a 53 years old woman with the tongue-based and supraglottic larynx SCC. The image A demonstrates a tumor at the base of the tongue and the right area. And the image B acquired 1 year after RT shows that after the treatment show the tumor already necrosis, and there's a lost tissue over this area. Okay. And this may lead to a long-term xerostomia and also dysphagia. In the swallowing domain, the organ at risk were identified as a predictor for swallowing toxicity, like we have oral cavity, PCM, superior, medial, and inferior, circumferential inlet muscle, supraglottic sparing. In the pharyngolaryngeal structures, there's early changes at the first week to the month. After the RT, usually it will lead to acute mucositis and also submucosal edema, and followed by dysphagia and also dyspnea in a severe space. So let me show you another case. It also an early post-RT here, changes in a 44 years old man presented with the SCC oropharynx of the right side. And this MRI showed there's a thickening and also the prominent mucosa contrast enhancements over here of the pharyngeal wall and also laryngeal structures as shown in arrow A here. Okay. And it also with the edema of the retropharyngeal space as shown in the arrow B here. And this also leads to the dysphagia. Okay. So another case is presenting in a 61 years old man show an early post-RT changes with a thickening of the supraglottic larynx mucosa with a significant reductions of the airway lumen at this area shown over here. As you can see, the stenosis already happened. In most severe case, the consequence reductions of the airway lumens can cause dyspnea, which commonly appear within the first 12 months, and after the treatment can potentially appear also even after several years. And this is a very rare case, but it's possible happen. It's a pharyngeal vertebral fistula presented in a 73 years old man late after RT. So the image A and the B shows that image A is a pre-contrast T1 weighted. Image B is a post-contrast fat saturated. MRI shows the mucosa necrosis in the posterior wall of the hypopharynx as you show in the star, as I show in the star here. Okay, with the pharyngeal vertebral fistula in here, this arrow B. And the spondylitis is this is a secondary infections of the vertebra. So is in here, is presenting here. Okay, this may lead to radiations induce the esophagus. Strictures is the most common late complicated complications of the RT, and it's usually occur 3 to 8 months, which is after the treatments. Okay, this usually happen, especially for the cervical esophagus, and because it is more fragile and also radiosensitive than the middle and also the lower of the esophagus range. Okay, so and this may lead to the poor oral intake and nutritionist and also nutrition deficiency, which patients couldn't eat at all, and it may lead to more chronic phase is patient may cause of that. Okay, and this is the pain domain, and the pain related to the toxicity is at the area of integral dose of the oral cavity, mandible, buccal, mucosa, supraglottic larynx. Okay, so the effect of the radiations related to the pain domains are mucositis, mandibular nutrition impairment, post-surgery with poor prognosis or late RT toxicities of the pharyngeal and also the oral cavity lesions. And for the late RT toxicity will occur up to 20 years post-RT, notably in those greater than 60 grade. It is possible happen. It is also possible happen, but it's a very rare case. Next is xerostomia, which is cause of pain also, and also dysphagia in a long or a short term. So while in this case is presented in a 67 years old man with oral cancer of the right oral mucosa who underwent treatment with local RT. So from the image A and the B at the level of the mandible, 1 month after treatment show minimal sclerotic bone marrow without cortical disruptions, while for the image D here shows that the level of the mandibula 6 months after the RT shows that there's a bone resorptions and also the cortical fragmentations presented at the dotted area over here, which is a typical finding of the subacute osteonecrosis. So this is also another case for the skin and subcutaneous soft tissue. Radiations damage to the skin most of the time. It causes radiodermatitis occur in 90 and above % of the patients who will receive RT. So the acute inflammatory reactions in the deep tissue usually occur within 2 weeks after the RT. And this CT image shows that the neck regions presenting in a 44 years old man with larynx carcinoma, shows an early post-RT changes with the diffuse thickening of the skin and plastima muscle, and also the thickening of the subcutaneous fat. So over here, and the arrow show here, and the deep tissue fat layer also involvement. Okay, so this is the grade RTOG assessment and the grading tool that usually the medical officer and also the oncologist, they will grade the patient's skin. So in a it's come with four grade. In a grade 0 is no change. Grade 1 is fade or dull erythema. Grade 2 is tender and patient's skin will start bright eczema with or without disclamations. Patient will be sore, itchy, and tight. In grade 3, patient represented with conflict, started with most disclamations, increased pain, soreness, edema. And for the severe grade, which is the ulceration, bleeding, and also necrosis happen. So in this general domain, there's a related toxicity in the brain and also the brain stem that usually happen for the head and neck patients. So the RT-related toxicity is tiredness and also weakness in the physical and also mentally. Symptomatic necrosis less than 3% in less than 60 grade. Neuropathy or necrosis less than 5% in less than with less than 54 grade. So when the nerve damage, it leads to pain, weakness, and also numbness or tickling in one or more part of the patient's body. And this is an example of our radiotherapy IMRT plan for the patients that presented with MPC T stage 4 nose involvement and without metastasis. So as you can see, this is the delineations of our contouring, and this is the planning. This is the tumor involvement, and this is brain stem. The brains, the brains is the brain stem structures over here, and patients is given 70 grade with 35 fractions. So as you can see, this is the focus of the dose is over here, and this is the PTB, and this is the PTB over here. PTB is a planning tumor volume is over here. Okay, and in head and neck patients, there are 10 potential radiations brain at risk, which involve in the patient. So as the closer RT target volume to the intracranial regions, the more radiations are intimate with the critical central nervous system structure, which associated with the risk of radiation induced at the cerebral toxicity. Okay. And these are the list of the organ at risk at the clinical, during the clinical dose tolerations for during our RT planning that will refer from our oncologists, physics, as well as the radiation therapies. So we are very alert for the patients, every single organ at risk for the head and neck patients. Okay. And for the RT head and neck patients, the fatigue and dose-related toxicity effect on the patient's quality of life and psychological aspect. So the cancer-related factors, we will patient that underlying comorbidities type of head and neck cancer, patients presented with HPV positive staging, and patient-related factor, they have the lifestyle, living lifestyle, patients, living lifestyle, treatments, adherence, decision-making, and also patient level of health literacy. So as you can see the pyramid narrowed down here, the treatment-related factor, those regions involvement in the organ at risk, treatment regimens, treatment toxicity, they are taken into account in this treatment-related factor. So with the all above factor, this may lead to patient's fatigue. Patient fatigue will be in terms of physical, emotions, and also cognitive. And this may give a huge impact for patients' quality of life and also psychology aspect, like anxiety, mood, the acceptance of illness, treatment, level of coping. The patient might be fear, the level of motivations in fighting off cancer. So as a radiation therapist, we will be very alert in the patient's clinical management for the head and neck toxicities, and we will provide a holistic care approach. Is also is because it is a vital to alleviate patient fatigue and also improve patient's quality and vitality of life. So we can in the clinical they have clinical symptoms screened by the medical officer or the oncologist, and they will provide a supportive care, psychology supportive care, and the radiation therapist that will for the patients who are more critical involvement with the organ at risk and a high toxicity of high radiation toxicity, the radiographers they will give more frequent imaging setup verifications, patient care counseling in pre, during, and also post-RT. And interventions we will start with swallowing exercise, organ at risk dose sparing will be done with the physic and also the radiation therapist during the treatment. Pain management, the radiation therapist will tell to inform the doctors that patients having pain, so doctor will usually give PCM or Dexa or morphine for the patients who are having the pain. And for patients who are having lost weight or tumor growth, resimulations, remove or repositions will be done with the radiation therapies. And this is my reference. I here end with my sharing. With that, thank you.
Terima kasih to Miss Leong for her sharing. A gentle reminder to all the audience, please fill in the feedback form at the link in the chat box below. So as we move to Q&A session, I will read the question from the chat, and if you want to ask a question, you can still type in the chat box. Okay, we have I read. So the first question, this is for our first panelist, Mr. Technologist Dr. James Chong. Regarding the exploration of body composition, particularly in the context of medical assessment, could you shed light on the typical radiation dose exposure associated with methods or technologies used to measure body composition? Additionally, how does this exposure compare to other commonly used medical imaging techniques? Okay, please, Dr. James.
Well, as short and simple, for DEXA scan, the dose is very, very minimal. It depending on the body size of the patient. So approximately about 0.001 millisievert up to 0.01. So compared to like CT, you probably receive 2 to 10 millisievert, and X-ray is probably, if for X-rays, a chest X-ray is about 0.02 millisievert. So is comparative is like 1/4 of a chest X-ray, so it's very, very minimal. So I would say it's pretty safe. So most of the time when people would like to have assessment when look at their fat volume, muscle mass, so you can go through the scans like 2 to 3 times over a certain period. So for example, if you are going for a weight training or you're going through a weight reduction program, so you probably have to do a pre-scan before you start your intervention, be it is with the diet or with your weight training. After that, in the middle, you probably observe again and evaluate the your results, and at the end of your intervention, then you measure again. I would say it's pretty safe and the dose is very minimal, so you can see your progress whether during your intervention whether it helps with your target or not, and your maybe your dietitian, your physician, your endocrinologist, or even your trainers can help out to further and strengthen or change the approach that to make your target achieved.
Okay, thank you, Dr. James. I hope it answered the question well. And then for the second panelist, Mr. Sasidaran, your discussion on the radiographer role in the interventional cardiovascular laboratory is fascinating. Could you shed light on how advancement in radiography technology have influenced this role and how radiographer can enhance patient outcomes in the context of interventional cardiovascular procedures? Thank you.
Hi, I'm intrigued with the question overall because coming back from in 2001, where cardiac catheterization was in an analog form, and within the next 10 years, span of 10 years, it transformed from analog cinefilm to digital. And currently, when we are at this current AI technology. So I tend to see that the future in medical imaging is fantastic in terms of enhancement of the radiographers in terms of radiation protection and all stuff. It actually coincides with the AI technology where it looks into patient safety and the patient comfort at this current moment. Yeah, thank you.
Okay, thank you, Mrs. Sasi. And then the third question goes to Ms. Leong. Mr. Leong Wuchin, your expertise in addressing fatigue and those related toxicities post-head and neck radiotherapy is crucial. Can you share insights into effective strategies or interventions that radiation therapies can employ to mitigate this side effect and enhance the overall quality of life for patients undergoing such treatment? Please, Ms. Leong.
We, as a radiation therapist, we have a patient care, and also we will daily see patient during the treatments. Like for head and neck cancer, right? The treatments is within 30 fractions to 33 fractions. So as the fractions going, the dose is increasing. So the toxicity, we as a radiation therapist, we need to minimize it. Like patients, they have ulcerations. So we will advise patients to drink more water. And started that, patient will be hard in like eating, patient couldn't eat. So usually the doctors, they will give patient LASIK, which is good, but some patients, they don't want. So as us, radiographer, we need to pursue patients to follow this kind of management, which is a pain management and also a nutrition management. So patient with the milk drinking through the throat, it will harmless to the patient oral and also the soft tissue as well. And patient care, swallowing exercise is very important so that patients can swallow. There's a no stenosis over here. And during the image verifications, advices is for the critical patients, is advises to be daily, but if let's say it's not that critical, 3 days in a week or once a week will be good. So we can see patients' airway, it is clear, and the brainstem is very important that affect patients' fatigue. Medulla cerebrums, of course, is very rare, but there is still the scattered dose scattered dose involvement there. So we will advise patient not to be sleep during the morning. It's good to be rest at the night. So morning can do some light exercise if patients they are tolerable. So this is during my research, I started to doing it, and patient seems good, but there's a re-stimulations happen, remote happen. So far there's no any like stop RT and also like no any delayments of radiotherapy. So patients they are doing good, and good thing is patients they already complete the RT. So radiographer, you need to give more patient care and be more alert for the patient's toxicity when especially during our verification image when we see the patients daily. And with the AI, I forgot with the AI, the radiomix is now getting hot in in the Western countries. So this radiomic, they can predict the toxicity with our regions of interest, but we need to like contour patients, which area that we are interested, and then we use this AI thing to generate the outcome. It's good that to have the clinical assessment together, then we can see more accuracy in the toxicity profile. Yeah, that's all.
Okay, thank you, Ms. Leong. And then one more question. This one is from Ms. Chan Lai Kwan, former president of MSR. For Dr. James Chong, is there a screening program for senior population for sarcopenia in Malaysia hospital?
No, as far as concerned, I've tried to research and go through all the studies available. Unfortunately, I do not see any, any program that available within Malaysia. Even in most of the country within the ASEAN region, I do not see a very specific program that has developed to target about sarcopenia. That's the reason that I brought this up. I think you have saw a diagram from my presentation earlier. So that was adopted from Taiwan. So well, actually they do concern. You see, if bone and muscle, they are all connective tissue. So if one part is not working, so you have more issues and problem later. So that's why I would like to increase the awareness among our people, then they can bring it back to their family and their co-workers about the importance of muscle loss. When you age, you tend to lose about 2 to 3 grams kind of good muscle within a year. So you have to maintain that good muscle to support your musculoskeletal system, so you can have a more healthy lifestyle. If not, then you probably just fell down, then you probably fractures, then your mobility will reduce, then your quality of life will reduce. That's why I would recommend people to go through body composition, then you know what's your muscle mass. I hope this answers your questions.
Okay, thank you. And then one last question. This one is for all the panelists. How do you see the collaboration and synergy among professionals in radiography and radiotherapy playing a pivot role in addressing the holistic needs of patient navigating through this interconnected aspect? Additionally, what advice or strategies to further enhance for improved patient outcomes? So how do we collaborate to improve the patient outcomes? Anyone? Mr. Sasi, maybe you have opinion on this?
Thank you, Mr. Zach. Just that in terms of University Malaya Medical Center, in terms of collaboration, we tend to do a lot of research program between we tend to have a school of radiography in the compound of the University Malaya, and then we tend to do a lot of research and within the department and the school and as well. So in terms of collaboration, yes, we can start off from the university level as well. In terms of hospital, and then there's many ways that you can collaborate between vendors in R&D sectors and all stuff. So yes, I would actually suggest we can start small within the context of the School of Radiography and the hospital, and then go up to the next level between the vendors and the hospital. Yeah, thank you.
Okay, Ms. Leong, maybe you want to add something?
Research is playing a main role in nowadays. Yeah. And research, we can see something which is different, and it will open our eye, which something that we couldn't see for the past previous decade. Yeah.
Okay, I agree. Yeah. Dr. James, Anything?
Well, I think this is not really rocket science. The most important thing is communication. So I think every hospital, you probably when you have a cancer center or you have any multidisciplinary approach, you probably form out a tumor board or something that you can discuss a case. When a case is presented, you will have all your multidisciplinary people, be it a dietitian, radiation therapist, your medical physicist, that can sit together with all the oncologists and even nuclear medicine physician to discuss about the case, what is the approach you're going to, share the decision that what's the best approach for the patient, that you can come up with a better conclusion or better outcome for the patient instead of single view kind of medical approach. It should be an integrated care plan that from multidisciplinary. So that will really help out for the patients. Well, definitely, I agree with the other two panelists. For example, research is really helping for making decision.
Okay, thank you to all the panelists. Yeah, so we have to work as a team. We don't consider we are a radiographer, diagnostic, or we are radiation therapist, but we are there to help the patient. That is our purpose to be there. So now it comes to the end. But now let me hand over the session to our president, Miss Pichiluna, for the discussion session with the president. And she will continue by announcing the next host for CPD Asia. Over to you, Miss Pichiluna.
All right. So I have to before we have our speakers leave here. Can I add some more questions for them? I received some questions here. And I think some panelists can also add if you have something to add here. So first question is for our first speaker. Can you, with the changes in the DEXA machine or the software over the time, as we know, it may affect comparability of results from scans conducted at different points in time. Can you share about standardization and calibration efforts that are considered specifically essential when doing longitudinal scans?
Well, in terms of calibration, I'm not a physicist, so I'm not really, into this kind of calibration. I'll leave it to the vendor or the medical physicist. But in terms of you talking about the result standards, most of the time we will try not to get the patients to consume like calcium kind of thing that will affect the bone density. While the rest is pretty stable for a DEXA body composition compared to BIA, which your body fluids or even your drinking water can varying the results from time to time. So because it makes the assumption of 76% of the body fluid within the body. So for DEXA is pretty standard. But for quality analysis, I would say I'll leave it to the professionals. Thank you.
Thank you, Dr. Chang. And for our second speaker, Sir Sasidaran, interventional radiographers play a crucial role in various procedures, including fractional flow reserve, as you have said. Can you share some challenges and solutions specifically related with equipment familiarity and maintenance of proficiency of radiographers using equipment and software that you employ in your department?
Yeah, like I mentioned earlier in my slide, that we do daily calibration and QA for each machine and all stuff. So your question again is regarding each modality or as general?
It says here that she's asking about specifically for FFR assessment.
Right.
Can you cite, how do you, what can you say about the most challenging concern? And do you have solutions there for RadTechs regards equipment familiarity, software, and how do they maintain their proficiency when employing using the assessment?
So in my last slide, the FFR is done by the CVTs and not by the radiographers. But to answer your question, basically, I mean, the FFR actually comes together like a R&D setup where each equipment is already been QC'd and all. So in terms of safety and quality, I don't think it's jeopardized in any way, unless you do it during the procedure and they tend to see any defects and all stuff. So those defects actually is coming from the vendor and not from the user as well. Yeah. But that is the reason why there's a lot of the operators in the world is opting for QFR rather than FFR, because they don't intend to use the pressure wire, because the pressure wire goes in directly into the coronary artery, and that actually can have a tendency of perforate the vessel and to dissect the vessel as well, especially in inexperienced operators like the fellows and all. So that is the reason why they are opting for QFR right now. Hope it helps.
Yes, thank you for that, Sir Sasidaran. And the last question I received for the third speaker is regards assessment or verifications as the first and crucial part in any imaging or radiation therapy. Can you share about the assessment tools and measures that are available in your RT facility for radiologic technologists?
Assessment tool, I would recommend for the mental first, because we need to assess the mental to stabilize the patients, to see how patient is stabilized. Acceptance of illness scale. Secondly is patient health literacy. The level of health literacy is very important to test patients' health indications, to see how patients good in making decisions, and it is to test patients the treatment's adherence, because radiotherapy things is very vital and important and also very crucial, as we all know that we not encourage patients to stop the RT, especially for the cancer patients that they are undergoing the radiotherapy. If patient haven't started the RT, you can stop immediately. It's better good that you stop, then you continue, and then you stop in the middle. So I will highly recommend the health literacy. And secondly is fatigue, because we can assess fatigue, the level of fatigue, concomitants with the toxicity together. So radiographers, radiation therapists, we can know, okay, patients, they have mucositis, or patient is tired because of what. And also at the same time, we can see patients' quality of life as well. This is the main things that we need to boost up patient quality of life during the treatments. When patients do not have quality of life, then we slowly go to depressions. Yeah, there are a few of it. And also cognitive impairment is good, that cognitive assessment is good for patients who having the brain radiotherapy.
Thank you for the answers for these last questions that I received from the audiences. Now, finally, I would like to call back all our panelists regards their own thoughts about the unveiling trifecta of body composition, interventional radiography, and post-radiotherapy challenges. So, or do you have any other additional thoughts on these? Because we have just heard very important topics from our three speakers. Do you have final comments or thoughts about the unveiling trifecta of the body composition in interventional radiography and post-radiotherapy challenges? You just unmute your microphone and feel free to give your thoughts.
Well, as I mentioned previously, it's really about multidisciplinary approach. When all our discipline, be it a medical practitioners or allied health professional, nurses, all our efforts is to improve quality of life of patients. So whatever we do is to produce the most positive outcome for the patient. Be it is what kind of technology, what kind of interventional approach. That's the multiple aim, that to prolong the life, prolong the quality of life, and make their life better for all our patients.
Yes, do we have any other additional and final thoughts on these?
I do agree, Dr. Jens, as well, because these things is multidiscipline. We need to communicate and work with other teams as well to boost our patients' quality of life. No? Main thing. Yeah. Thank you.
All right, and I would definitely agree. Regards us in the academe, or maybe about CPD, we should also maybe think of integrating this in our educational programs. We consider offering of cross-disciplinary training for our healthcare professionals, so we can foster more collaboration and, of course, the holistic approach to patient care. So I guess we don't have any more other comments and additional thoughts from our esteemed panelists. With that, let me now proceed with the next session. So before that, I'd like to say again, thank you to our moderator, Muhammad Zirwan bin Ahmad Zainuddin. And again, thank you very much, presidents and panelists. The Malaysian Society of Radiographers has just provided us with 3 great speakers. I love the topics. I do hope that you enjoyed also learning. And again, you can watch a replay via the YouTube channels of the MSR, the PARI, and the VART. So again, thank you, Dr. James Chong, Mr. Sasidaran Ramachandran, and Ms. Leong Won Chin. We have learned so much from your interesting and very important discussions, and we hope to hear from you again next time. But of course, in the interest of time, we have to cut from here to give way for the closing session. And I know you are all very excited to know about the next exciting online CPD Asia schedule next year, 2024. So without further ado, please welcome for the Macau Radiological Technologies Association, MRTA. Let's call in Madame Cora Nang to give an invitation.
Hello, it's Cora from Macau Radiological Technologies Association. Here, I would like to introduce the next Asia CPD that will be hosted by our society. The 33rd Asia CPD, also known as the 34th CPD program of the Macau Radiological Technologies Association, is going to be held on the 24th of January 2024 from 7 p.m. to 9 p.m. Macau time. There will be 2 speakers in this CPD who will bring us respectively the latest knowledge about the quality assurance and quality control of medical imaging in Macau public hospitals, and the role of frontline radiological technologists in the diagnostic and management of kidney disease in Macau public hospitals. Please stay tuned to our next Asia CPD. I wish you a Merry Christmas and a Happy New Year. Looking forward to see you all in next year, 2024 January. Thank you.
Thank you, Chairman Cora Nang of the Macau Radiological Technologies Association. Definitely will be saving that date, and we hope that we will again give our support, perfect support of attendance to the next CPD Asia in January 2024. So in closing, we give thanks to the support of our MSR sponsors and the VT Healthcare Vietnam. Also, we are grateful to our 3 great speakers. Most of all, we are sincerely thankful to the host society, the Malaysian Society of Radiographers, to President Sawal Marsaid, to all your officers, to our moderator, Mr. Muhammad Zirwan bin Ahmad Zainuddin, and the amazing MSR organizing committee. Also to the support of all the member societies, presidents, the chairman, to all our hardworking CPD Asia team, and to all the registered participants who have made this online CPD Asia program a very successful one. We shall see all of you again next Happy New Year during the next Asia CPD 2024. Again, I am Peachy Luna, and I say thank you everyone and have a great day.
Thank you. Thank you.
Terima kasih.
Terima kasih.
Bye.
Thank
Thank you. Thank you. Okay. Bye.
Congratulations.
New Year.
Terima kasih.
Terima
Ya,
kasih. Terima kasih.
ya. Izin live. Selamat tahun baru. Ya.